Welcome to the webinar, Biobanking and the Role of the Surgical Oncologist in Translational Research. We will go through opportunities for international networking in biobanking in gynecological oncology with the example of the GYNOCARE COST action. Challenges to overcoming in establishing a cancer biobank, ethical research and general data protection regulations, the experience of the Irish National Biobanking Working Group. We have a fantastic panel of experts for this evening's session, which have been carefully selected to giving different perspectives. So by the end of the webinar, you will have an understanding about the possibilities of biobanking is providing for participating in translational research, have a better understanding of the process of establishing biobanks. Please note there is a Q&A function and we would like you to ask questions as we go along during the webinar. Let me hand over to Mariela, who will introduce the panel of speakers tonight. Over to you, Mariela.
Thank you very much, Afsana. Then I would like also to introduce Dr. Afsana Elanko, who is a senior education and leader in healthcare based in UK. And secondly, we have our wonderful group of panelists. We will start first with Professor Jean Calleja, which is head of the Department of Anatomy at the Faculty of Medicine and Surgery at the University of Malta. She is obstetrician and gynecology by training, and she has studied and worked both in Malta and in UK, specifically at the University College of London and at the University of Leeds. She is currently chair of the Cost Action GYNOCARE, which is an European-funded collaboration in science and technology, focusing on the collaboration of European Network for Gynecological Rare Cancer Research from concept to cure. As part of this GYNOCARE COST action, international experts get together to work in 5 different work packages, one of them being specifically biobanking for rare gynae cancers. In her presentation, Professor Jean Calleja will be elaborating more on the work of GYNOCARE and how this work can be applied to all other scenarios involving cancer, being it rare or not. Secondly, we have Dr. Sharon O'Toole. She is Senior Research Fellow in Trinity College Dublin, working in the area of gynecological cancers. Her research focuses on diagnostic and prognostic biomarkers and cancer metastases. She sits on the National Biobank Working Group, who are focused on harmonizing biobanking approaches in Ireland. She works closely with charities and patient advocacy groups and coordinates a national initiative for awareness of gynecological cancers. She's also member and leader, actually, of the Working Group 2 of the GYNOCARE COST action. And finally, we have a surgeon in the group, Dr. Rita Mukhtar. She's breast surgeon at the University of California, San Francisco, where she's associate professor of surgery. Her interests are in lobular breast cancer and surgical education. She is national funded researcher in invasive lobular carcinoma, and she is associated program director for the general surgery residency. Last but not least, we have our man in the group, professor of surgery. This is Professor Wolfgang Tassler, who is head of the Department of General and Visceral Surgery at Red Cross Hospital of Munich, Germany. So after this presentation, I give the word for Jean. It's you.
Thank you so much. Thank you, Mariela. So I'm loading my slides.
Okay, so the first speaker is going to talk about the opportunities given by the international networks for biobanks by gynecological oncology. So over to you, Jean.
Thank you so much. Thank you, Afsana, and thank you for inviting me to be part of this panel. So we're going to be using GYNOCARE, which is, as Mariela very well explained, it's a European network for gynecological rare cancer research. And this is a cost action focusing on a very niche area. Now, just a little bit of information about COST. So COST is a funding stream by the European Union, which specifically funds cooperation in science and technology, and it specifically funds networking, which is very different from many other grants from many other funders. So the idea is that you group experts coming from different disciplines, and each of these experts, they have one common theme in common between them. And in our case, it is the gynecological rare cancer. So why rare gynecological cancer? So may I also take the opportunity of stressing the fact that this is the very first cost action, or among the first cost actions, specifically looking into women's health apart from pregnancy. So there have been a number of pregnancy-related cost actions in the past and even ongoing, but this is specifically the first one looking into women's health and specifically cancer and specifically rare cancer. So what makes it unique, as you can see, so it is dealing with rare types, which many a times they have been ignored, but again, thanks to the big developments which have been happening recently and the great awareness, there is focus on rare diseases, and rare gynecological cancers are, of course, one of them. As you are probably aware as well, the European Union has a special mission. One of the missions is actually addressing cancer. So making cancer research and cancer eradication possible, which is mission impossible, but making it possible. So again, these rare gynecological cancers, are they that rare? I mean, if you take them all together, they actually are not rare at all. Why? Because if we look at the annual incidence of the 18.5 million women yearly being affected by gynecological cancers, up to 50% of them, that is, just over 9 million women a year, are affected by what we call rare gynecological cancers. So what are rare gynecological cancers? Now, as a cost action in one of our initial meetings, there was a hot debate of whether to restrict ourselves to the female genital tract or actually include breast. Because we are very much aware that in many countries it is the gynecologist who is also the surgeon involved when it comes to breast. However, as a group, we decided that the main focus will be the 40 rare types of gynecological cancer. And again, this classification was adapted from a recent publication, which is the IARC WHO Blue Book, which is the classification of female genital tumors. And in fact, I mean, one of the editors of that book, as you'll see later, is actually the working group lead for the research part. And why did we decide to stress on these? Because, I mean, they are rare. And when something is rare, when a condition is rare, unfortunately, I mean, be it gynecological cancer, be it breast cancer, be it any other type of disease, I mean, if it is rare, it is more likely there is an increased risk that there is a delayed diagnosis, delayed correct diagnosis, which unfortunately, I mean, if there is a delayed diagnosis, there is also poor outcome. It's more likely to lead to poor outcome. And again, coming back to these rare gynecological cancers, I mean, the other issue is that they tend to, in general, happen in the younger population, in girls, sometimes prepubertal girls or peripubertal girls or young women, where they might not be the ones who are very forthcoming when it comes to thinking of a possible malignancy. Okay? Also, when it comes to diagnosis, when something is rare, unfortunately, there's also a problem with the system, because I speak for myself. I mean, coming from a small country with just over 500,000 inhabitants, I mean, and that is Malta. Unfortunately, the expertise you get, I mean, the number of cases which, for example, a pathologist would see, if you are working and you are, let's say your area covers a certain population, I mean, if something is rare, you're likely to see such a case maybe once a year or once every 2 years. I mean, the same happens if you are in a big country, okay, but you're working in a district general hospital. And of course, I mean, in your career, you might only see occasional cases. So, but if you happen to be the patient with that particular rare cancer, I mean, of course, you might not be well served or well managed, simply because you are unlucky enough to have a rare disease. So why the importance of this cost action? So why are we happy that COST actually granted this funding for 4 years with a possible extension of an extra year? The reason is because we are basically 30 countries and growing, with over 130 members from different parts of Europe and beyond. We have the US, and we have parts of Africa, and even states which are, not part of the European Union, but of course work closely with the European Union. And there, each individual country has their own experts who are provided a platform where they can network and they can share ideas and share expertise and learning from each other. And ultimately, by training the professionals, being pathologists, being scientists, being researchers, being ethicists, being lawyers, in that case, we are able to serve patients wherever they are, whether they come from rural areas or affluent countries or less affluent countries, they're served better. That is the aim. So how is this network, how is this cost action organized? So like many other European projects and like many other cost actions, the work is divided into 5 work packages. Okay, as we said, I mean, the members span from all over Europe and beyond. Working Group 1 deals specifically with the basic research, okay, and there we have researchers, we have bioinformaticians, we have pathologists, we have oncologists, who basically look at the basic research. And by the basic research, it also includes the understanding of, the difference, be it genetic, be it at molecular level, when it comes between different cancers, and especially different rare gynecological cancers. But of course, the information there, I mean, the basic science in that can be translated to so many other different cancers and so many other different diseases. But by understanding the behavior of these different tumors, then that feeds into Working Group 2, which Sharon O'Toole will be talking about soon, which is specifically dealing with biobanking. However, I mean, apart from the hurdle of being able to have the infrastructure to have a biobank, you also need to know what tissue you're sampling, like what's the nature of your tissue. And it's not just whether it is a tissue sample, a DNA sample, an RNA sample, whether it's urine, whether it's blood, but even what you're collecting, basically. So by knowing what you're collecting, you know that if you don't have a mixed bag of tumors, for example, so if we're looking at ovarian cancer, it's not a mixed bag of different tissue types, different histological types of ovarian cancer, for example, but you know whether it is, let's say, a serous, I don't know, a serous carcinoma, for example, or a germ cell tumor, or you know what you're collecting, because once you know what you're collecting, can you then know what's in your bank, and can you then, if then you move on to doing clinical trials or doing further studies on your tissue, you know what samples you're dealing with. In fact, that working group works in very close collaboration then with Working Group 3, which is basically, it's led by a lawyer who's an expert in data protection and the legal aspects of consent and of the ethical issues involved with patient recruitment and patient participation. So as I said, I mean, they work together very much so. And then ultimately, working group 4 is the working group responsible for reaching out to industry and to the pharma. And then working group 5, basically the idea is that once you have gathered all this knowledge, we can start thinking about designing smart clinical trials with an aim of being precise and leading to precision medicine, which is tailor-made to the patient. And that is something which every patient will benefit, especially if it's a patient with a rare tumor type. Okay, so this is again in summary what the aims of the different working groups are. Okay, so ultimately the aim would be that following the networking which would be happening during this cost action, we would be able to move on to designing international high quality innovative clinical trials which are tailor-made to the patient. Okay, so basically this is just to highlight, I mean, the people who are leading these groups, and of course within each group you've got a whole team of different experts, as I said, who range from the physicians, the oncologists, the pathologists, the scientists, to also the legal aspect, the ethical aspect, and the pharmaceutical aspect. Okay. And in fact, here you can see Sharon, who will be detailing more about her work in the working group 2. So again, what's special about this cost action? And incidentally, those of you who are interested in joining, I mean, we are always accepting experts on board, be it from whichever discipline you're coming from. So the focus is on capacity building by increasing knowledge on rare gynecological cancer, and that is done by connecting high quality scientific communities in various disciplines, existing networks, and importantly, policymakers, industrial partners, and above all, patient organizations across Europe and beyond. And that's where we have a lot to learn from Sharon through her work with Engage and other similar agencies. There's also, as I said, I mean, the coordination contribution to research roadmaps dedicated to connecting innovative basic research to biobanking and ultimately feeding into smarter clinical trials, and also creating a platform for sharing best practice, which will live beyond the lifetime of the project, and also setting the stage for the legal and ethical requirements revolving around patient recruitment, patient consent, and storage of biobanking, so that advising policymakers across the board, so that ultimately you also can share you can share information in a legal and ethical way with other centers within your country and even outside your country. Especially, this is especially important when it comes to rare gynecological cancers. And equal networking opportunities are given whatever the stage in your career, and actually preference is given also to early stage career researchers in order to set the stage for the future. So far, thanks to this network and thanks to the work of everyone within this network, I mean, since just 2 years, basically under 2 years, we've managed to publish many papers, I mean, in cancers and the International Journal of Molecular Sciences, and they've ranged from case reports to review articles. And this is, for example, the very first article which the cost action, I mean, at the time were only just under 40 participants, and that's the first one to set the roadmap of where we intend to go. And as I said, I mean, whichever your interest, I mean, whether it's gynaecology or whether it's any other type of oncology or rare rare. I mean, there is so much similarity when it comes to the design and the creation of your biobank. I mean, the way you deal with looking at a particular condition from the molecular, from the genetic. I mean, ultimately, they all boil down to the same structure, and then it's what is attached to that, which might vary, you know, but ultimately it's the same concept. It all boils down. That's why the multidisciplinarity is so important. And again, here are some examples of other papers which have come out of our action, and still there are more coming out. And just to come close to wrapping up, such networks give you opportunities, because our very recent venture has actually been looking at gynecology, I mean, especially gynecology, and with particular rare tumors, I mean, developing in for what we now consider maybe rare situations, which might not be rare in the near future, and that's looking at space flight and the risk of developing cancer, female astronauts or future travelers who happen to be female and they're exposed to radiation and microgravity. Okay, so anyone who's interested, feel free to contact me or visit our website, which is gynocare.net. We are happy to continue collaborating on open access publications, and COST specifically encourages open access, again, so that even beyond the lifetime of this project, and the information is out there and is easily accessible for others to use. Also, we organize conference, and we actually also encourage attendance and participation in conferences. We do training schools, so we've got one coming up in North Macedonia in September. There's also the possibility of doing short-term scientific missions where, for example, someone who wants to gain more expertise in a particular area can visit the Center of Excellence and actually cost funds for that. And even there is also the possibility of virtual networking. I mean, this started off, of course, because of the COVID pandemic where people couldn't travel, but it's a tool which COST has kept, and that's very good, because I've now learned that certain advances, I mean, you don't need to meet physically sometimes, but even that we're virtual, like we're doing in this webinar, for example. Okay, so basically, here you're actually seeing a satellite shot of Malta. This is where I am at the moment and where I've actually lived for most of my life. So a small country, and when you see the big picture, so here is Sicily, here is Italy, and of course the rest of the world. But thanks to opportunities for funding and knowing also how to make the best use of them, with the intention, as I said, to leave a mark and make a small step forward, and in order to help women with rare conditions, especially rare cancer. And you're helping not just the women and their families, but of course colleagues, their own colleagues, because they learn more and are able to help more people. So thank you very much for your attention. As I said, anyone who wants to visit our site, that's gynocare.net, and I'll be happy to discuss any after the end of this session. Thank you so much.
Thank you so much, Jean, for an absolutely fantastic presentation. You've given us such a wonderful overview. I'm sure our thought processors are excited at the moment. Let's hand over to our next speaker, who's going to talk about the challenges to overcome in establishing a cancer biobank, the ethical research and general data protection regulations. Over to you, Sharon.
Sorry, I just need to unmute there. Thank you very much, and thank you, Mariela and Afsana, for giving me the opportunity to address the society today, and I'm delighted to be here. So I'm just going to just see if I can change slides here. I have no disclosures. I'm just going to give an overview of what I'm going to cover. I'm going to talk a little bit about what biobanking is and how it supports research. I'm going to look at some of the key requirements for biobanks if people are setting up a biobank. I'm going to talk about some of the challenges that we had here in Ireland and why we established the National Biobank Working Group. And then I'm going to just look at the role of patients in that biobanking process, and then just talk about some of the work that we're doing in the cost action. So I'm going to show you this short video, first of all, and this was done by a colleague of mine, Margaret Dunn, for another project. And it's really to, I suppose, promote the idea of biobanking and research amongst the public and patients, so that they're more familiar with the term biobanking. So hopefully this will play okay for you. I'm just going to play, it's just a short video.
Did you know St James's Hospital is linked with Trinity College Dublin, who do research studies into cancer and other illnesses? If you attend St James's Hospital, you may be asked to donate samples for research. What happens if you say yes? You will meet with a research manager who will explain the study and ask for your permission to take a sample and access your information. You will sign a form. Your samples will be coded and may be used for experiments immediately, or may be stored for use in future studies in our biobank. Your data is protected by law. Scientists only see coded information and only what they need to run the study. Why should you participate? To help us test and develop new and better treatments, and to help us understand cancer better. Research can take a long time, especially for rarer diseases, and we need big numbers to make big discoveries. Your participation today will help future cancer patients. What happens to your samples? We can measure a lot of different things, from very small drops of blood or pieces of tissue. For example, in our lab we test new drugs, investigate how cancer develops and progresses from damaged cells, for example, Barrett's esophagus. Look at how immune cells work in cancer. Examine what different genes do in cancer. And study how obesity is linked to cancer. This research helps us answer questions like, why do some people respond to chemotherapy but others don't? How can we make treatments that can work for more people? And how can we make our immune system attack cancer? All this research is made possible by patients donating samples and by funding provided by national research funding agencies and by charities. Thank you.
So it's just a short video, I guess, that explains the process, and just to say that it was created with students, with transition year students, so around the age of 16 or 17, who really didn't understand what biobanking was or what the process of research was. So in conjunction with the researchers, they developed a storyboard for this. And, you know, we use it now, and it's showing on all of the video screens in the hospital here in the outpatients department, so that, you know, people become familiar with the terms that we're using, and in particular biobanking. So, and it's something that can be, I suppose, converted into different languages. You know, the template is there now for other groups to use. So we'd be really happy if others use this storyboard as well in other countries. So it just might help people promote the whole biobanking story and get more patients involved. So just to say then, so what are biobanks? And I think when we're talking about biobanks now, we talk about, you know, the human material, but we've also got to remember the data, and the data has become really important since GDPR. It's making everyone think about data, but there's lots of different types of collections that you can have within a biobank. They can be clinical, using, you know, tissue, surplus tissue from surgeries or from the pathology archives, diagnostic material, blood, urine, you know, there's lots of research collections, therapeutic stem cells, you know, there's patient or population-based biobanks. So it's important, I suppose, that the data, everything is properly annotated in these biobanks, and that they're available for future use with the appropriate governance mechanisms. And there's many benefits of biobanks, you know, all the advances we see in the omics sciences, because, you know, the material is there and it allows high throughput, cheaper analysis. There's the creation of all the big data and analysis of big data that goes on. The connection to clinical data is extremely important. You know, I mean, a sample is useless without the clinical data that's associated with it. And, you know, the benefits also include hypothesis generating trials, resources to advance patient treatment, and and it has a key role in precision medicine. And so I suppose when we talk about biobanking, I liked this figure, which kind of gives a triangle of the various principles involved in biobanking. And I'm going to go through these individually, but I'm going to spend a little bit more time on the whole informed consent and you know, patient enrollment, because that was a challenge that we saw here in Ireland, and particularly with GDPR. So I'm just going to talk, I suppose, about how we address that challenge. But so there are many principles here, and I'll just go through them individually. So we have the whole, I suppose, the whole governance part of biobanking, that it's really important, you know, that you have a good governance mechanism in place in the biobank, you know, and that it's transparent and accountable. And there's many best practices out there. You know, we have BBMRI, ERIC, we have ISPER best practices. There's lots of resources that people can use, you know, to ensure that there's good governance, ethical and legal standards in place in a biobank. Sorry now. So you have the ethics, privacy and security. So I suppose ensuring that samples are used ethically that are stored in a biobank, and that's really important. And I guess for every study and every new study that we would have here, we have to get ethical approval or get an amendment to our ethics approval, so that an ethics committee can decide that, you know, this is an ethical study to do, and this is extremely important, and you know, it's the least that patients deserve if they're donating samples to a biobank. Then we have the whole facility design and safety surrounding that. You know, these are some of the basic things. You know, where are you going to store the samples? You need to have the proper facilities, and you need to maintain a safe environment, and they have to be properly monitored. You know, we have -80 freezers where we would store all our samples, but if that freezer goes down and it hasn't been monitored, then, you know, you could lose years of research, and it happens. So it's important that, you know, a proper monitoring system is put in place for biobanks. A quality management system, and this is becoming more and more important now, because we now have an ISO, which is an international standard for biobanking, and it's the ISO 20387. Now, there aren't that many biobanks that have achieved this. It's a new accreditation that has come in, but this is what biobanks will be working towards, you know. And I think going forward, and I know here in Ireland that a lot of our funding agencies, if you're going to be using samples from a biobank, they'll require this going forward, and it's going to be expensive, and it's not like, I suppose, that smaller biobanks will be able to afford to get ISO accreditation going forward. So, but I think, you know, the standards that are laid out in this are something that we can all work towards, you know, in terms of a quality management system, and try and achieve as close as possible. But I think going forward, and I know here in Ireland we're pushing for a national biobank that could achieve this standard and have the proper funding in place to do that. The biospecimen collection and processing, when you're starting out with a biobank, it's important to think of the types of specimens that you might collect and what procedures might be involved in getting those specimens. And, you know, many biobanks would collect tissue, but then like our own here, we collect blood and other bodily fluids. Like we collect acidic fluid from some of the ovarian samples, and then it's how you process those samples to ensure you're getting the right components for storing for future analyses. As I said, the storage, retrieval, distribution, if you're sharing the samples with others, it's important to have proper sample distribution procedures in place, but also the legal requirements that come with that as well, if you're transferring data, and material and data transfer agreements that need to be put in place if you're sharing your data with anyone. There's lots of systems for managing your data, and I know a lot of smaller biobanks might use something like Microsoft Excel or Microsoft Access, but there are more complex systems, and some of our group here use the Module Bio system for data management, and some of our other groups are moving over onto this, you know, which allows, I suppose, and what ISO will require is proper tracking of samples and where samples are, and having everything barcoded coded. But again, I know smaller biobanks may not be able to achieve this just yet, but going forward, I think you know, there'll be proper data management systems needed if you're going to meet the ISO standards. So, as I said, I was going to talk a little bit more about the informed consent process for patients taking part, not patients, they may not be patients, but for people taking part in a biobank, and really, I suppose, conducting this in compliance with good clinical practice, the Declaration of Helsinki. And, you know, with GDPR came other legislation in some countries, and that's something that we had to deal with here in Ireland. So, I'm sure everyone knows that as of now that, you know, GDPR came in back in May 2018, but, you know, the principles of GDPR are outlined everywhere, I think, you know, so we all have to achieve this in terms of our research biobanking. But I suppose here in Ireland, we had an additional layer of legislation that came in on top of that in terms of explicit consent, and they're called the health research regulations. So it made it quite difficult, I suppose, for biobanks that were in existence prior to GDPR, because it was felt that they didn't meet the standard of explicit consent. So a committee was established called the Health Research Declaration Committee, where biobanks had to go to see if we could get a consent waiver, or else we were required to go back and reconsent all patients who had donated to biobanks. And this was difficult because many patients had passed away, but it also raised questions of, you know, approaching people who may have moved on from their cancer diagnosis and didn't want to revisit it, and upsetting people. And there was lots of things discussed at the time. But the Health Research Declaration Committee now, you apply to them to see if you can get a consent waiver for biobanks that were in existence already, and we achieved ours last year, which was great, which allows us now to use our samples going forward. But we have to go back to the committee for every new study that we do with those samples. So it's a lot of paperwork, but at least those samples don't go to waste that have been in the biobank for many years. And the benefit of having them in the biobank for many years is that we have the clinical follow-up for those patients. You know, we know how they responded to treatment, and that's the benefit of having the longitudinal follow-up with the biobank. So I guess when this legislation came in, informed consent, patient information leaflets and informed consent became huge forms, and we were starting out with something like a 24-page document, which seemed crazy to be going to patients with such a large document. So our first point, and it was really the establishment of the National Biobank Working Group, was how were we going to deal with this, and how were we going to be asking patients and going through all of this, these forms, detailed forms with patients. They were like a legal document, really. So what we did was, so the National Biobank Working Group kind of was set up with people who felt really strongly, I suppose, about trying to improve things after the health research regulations were brought in, and to develop, I suppose, and harmonise our efforts in terms of patient information leaflets and informed consent. And what we did was we involved patients from the start. We said, if we're going to patients with these forms, then we need to know how they feel about it, you know. So we got patients to come on board our committee to help us design this harmonised form that we could use that all biobanks could use as a template in Ireland. So, so our group established, we had a large workshop with patients. We had over 100 patients and public involved in that workshop. And from that workshop, we presented them, I suppose, with a draft patient information leaflet and consent form. But that draft was developed in conjunction with patients as well. So then we had a report. We got a professional lady to do a report from that workshop so that we could capture all the information that came through. And then we redesigned our form, and we have published this now, and it's available on open research, you know, so people can see the process that we went through. They can see our template that's there and what came from the workshop and what was developed. And and we're glad to say, and I'll talk a little bit in the end, that our national COVID biobank is now using that template as well for their biobank. Now they obviously have to amend, and you have to personalize certain aspects of that depending on what your project is about. But it has been a very useful, I suppose it's been a useful journey, and just really having the patients involved has really made us think about what we're putting into that patient information leaflet also. This was another thing that came from that workshop, was really a lot of people have literacy issues, and it's having this diagram, I suppose, which could explain the process in pictures for those who have literacy issues. We also developed a simplified version of our patient information leaflet, which is given to patients and it's left over in the clinics and the hospitals so that people can pick it up, just saying why are biobanks important in research. We held an event which explained about biobanks and research, just to gather more, I suppose, interest from patients. And we had a number of patients speaking at this event. Very successful event. People were saying they didn't know about biobanking prior to that. Now they would be happy to get involved. And we won a healthcare award for this event. So we were delighted with that. There's also opportunities if someone is starting off and to promote biobank in your area, to have, you know, different podcasts. The European Day of Research also, we held an event on biobanking. So lots of opportunities to promote public awareness of biobanking. Now, just to move briefly onto the cost action and what we're doing in that, and we had what Jean talked about, the virtual mobility grants. We had one where we wanted to harmonise, I suppose, a common data set for biobanking of rare gynae cancers, and really to see within our cost action group, what are people, you know, what are people biobanking and what parameters they're collecting. And because it's important that we try and harmonise, so we're all collecting the same information, and not like 5 years down the line where you say, oh, I wish we collected that. So it's to try and see what's everyone doing now, what's best practice, and can we harmonise our efforts so that we're all collecting the same information. So we developed a survey as part of that, which has gone out to all of our members, just looking at, you know, how do they classify even the rare gynae cancers, because there's a number of different ways to classify gynae cancers, and what material they're collecting, what clinical details, you know, are they collecting, follow-up information. So we'd be very interested to see the outputs from this survey, so it'll help direct our future directions, I suppose, in terms of the cost action. And just this kind of really just summarises, I suppose, the whole process of biobanking, going from the patient all the way down to medical research, where there's many benefits in terms of biobanking. And this is our national COVID biobank. So we don't have a national cancer biobank yet in Ireland, and the first national biobank has been a COVID biobank, but we're hoping this will set the scene for many other biobanks going forward. And it's something we're really pushing for as biobank scientists here in Ireland, that we really do need a national biobank, and one that meets the ESSO standards. And I think, but this is a first step, that we have a national COVID biobank, and it's great that they're using our template that was developed as part of the working group. So just in summary, I suppose if someone is starting a biobank, is to think of, well, what's the purpose of it, and to try and future-proof it, so that it's, you know, you kind of don't go back and say, oh, I wish I had collected that. You know, try and think to the future when you are developing a biobank. How are you going to fund and sustain it? I would recommend involving patients from the start and educating the public on the benefits of biobanks, so you'll have buy-in from them. Work as close to the ISO standards. There's lots of resources, you know, in terms of ISBR best practice. Think about the governance and data protection. Really, they're really important from the start. And you need to know the relevant legislation in your country, because, you know, lots of countries, you know, interpreted GDPR differently and put in extra legislation. So it's important you're aware of what's happening in your country and how you can share samples. So that's all from me. Thank you.
Thank you so much, Sharon, for an absolutely wonderful presentation and going through the detail, especially of how to involve the patients in that journey. Our next speaker is going to talk about the role of the surgeons in biobanking, and both Mariela and I were very excited to have Rita on board. So over to you, Rita.
Thank you so much. Thank you, Mariela and Afsana, for the opportunity to speak. I'm excited to speak to this group. As mentioned, I'm a surgeon at the University of California, San Francisco. I have no disclosures. I had the opportunity to meet Mariela at a recent lobular breast cancer conference in Utrecht. And I'm really here speaking to this group as a surgeon to give a little bit of my personal perspective on some of the practical aspects of being involved in some biobanking efforts and what it's like to be a surgeon involved in research, and a little bit about my path towards getting involved. And I hope that this might be helpful, especially for younger surgeons, people who are maybe just finishing their training or early career surgeons. So I'll share a little bit about some of my personal experience and practical aspects. I'll share how surgeons can be very helpful in biobanking and translational research efforts, and how biobanking and translational research efforts can also be very helpful to surgeons themselves and their career development. So just to give a little bit about my background, since I know every country has a different training path, and how did I get involved in surgery and being a surgeon researcher. So I did my undergraduate training at UC Berkeley, and then did the rest of my training at UC San Francisco, so medical school, residency, and then a fellowship. And in our residency training in the US, we often will do a couple of years of research in the middle of our training. So I did 2 years of training in clinical research, at which time I did courses on statistics, epidemiology, and clinical trial design. And for any surgeon who's interested in being involved in research in their career, I highly recommend obtaining training in biostatistics, as that I think has been some of the most helpful training that I've done. I then practiced as a general surgeon for a couple of years before going back to UCSF as a faculty member. And as has been mentioned, my research interest has been really focused on invasive lobular carcinoma, which is the second most common type of breast cancer. So at my institution, I've had the opportunity to be involved in a number of studies where we are collecting tissue samples. Some of these have been at the institutional level, and some of them have been through cooperative groups, so multi-center trials, either in the state of California or across the US. And for the institutional studies that I've been involved in, some of them are disease specific. So for patients with breast cancer, for example, collecting breast tumor samples after people have undergone neoadjuvant therapy. Some of them have been for people who don't have a specific disease. So for example, we have some endocrinologists who are interested in looking at adipocytes and would like to obtain samples of normal fat, and approach surgeons who are operating on patients for elective conditions to obtain samples for them. Same thing with some dermatologists, for example, who want skin samples. So there have been some opportunities to collaborate with people at my own institution who are doing these sort of smaller individual studies that are banking tissue. And then some of the cooperative groups that I've been involved in have been the Translational Breast Cancer Research Consortium, which is a multi-center group involving many different states across the US, a neoadjuvant chemotherapy trial called the I-SPY2 trial. And then, of course, in addition to collecting tissue in the operating room, there's also many requests to collect tissue and be involved in studies for people who need tumor biopsies done, for example, in the clinic. So a lot of metastatic breast cancer trials that are evaluating tumor response for things like chest wall involvement or unresectable disease. And some of the practical aspects, so as a surgeon, like how does participating in a biobanking study kind of impact your day-to-day life? So sometimes there isn't enough tissue to obtain a sample from. So for example, if it's a neoadjuvant study and the patient hopefully has had a very good response, there might not be any tumor left. And so that's something that you sort of have to think about. On the day that you're going to be doing the operation, one thing, you guys are probably more organized than we are, but one thing I've learned is that you don't want to be getting consent in the morning of surgery as you're walking into the preoperative area. So that's not a great thing. You have to think about what are you going to do with that specimen once you collect it? And so you have to work very closely with the people who are organizing the study, and being involved in organizing the study from the beginning, I think is helpful to know, what are you supposed to do with that piece of tissue that you obtained? Do you put it in special media? Do you put it in saline? Do you need any special equipment? Who's the person that you're going to call to come and collect the tissue and make sure that it gets where it needs to go in the right time frame and that you don't get degradation of the tissue? So these are just some of the practical things to think about when you're getting involved in a biobanking study. So why is it important for surgeons to be involved in these kinds of efforts? And I do think that surgeons bring a lot to the table, and many of the people on this call have written extensively about this. Surgeons are kind of the point of access for tissue samples that need to be obtained intraoperatively. And this can be, of course, much more comfortable for patients. If they're having surgery, they're going to be under anesthesia. So for example, some of the studies I've been involved in involve obtaining bone marrow biopsies. And so we're able to do those when a person is under anesthesia because they're having their breast cancer surgery at that same time. Surgeons can provide access to tissue or tumor that cannot be accessed by a needle biopsy, for example. Surgeons have particular knowledge about how to acquire tissue and where it is relative to the tumor. This is very important in terms of making sure that there's still enough tissue for the pathologist to be able to make a proper diagnosis and evaluate the margins. Surgeons are very aware of specimen handling and the technique for, not cauterizing the sample so that you're actually sort of destroying the tissue before it's being banked. So making sure that the tissue is still in very good condition. And surgeons are very well acquainted with communicating closely with pathologists. And I think that collaboration between the surgeon and the pathologist is very important to make sure that the right piece of tissue is being collected and that you're still able to provide proper clinical care for that patient. The other really important point that I've realized in the last few years is that for a person who's having surgery and is being asked to participate in a tissue collection or biobanking study, patients will often turn to their surgeon and ask the surgeon if this is something that they should do. So this is something that you probably have all experienced and I've experienced. And so the surgeon really has to be on board and supportive of these studies to help promote accrual of patients. And of course, surgeons being part of the research team is important because surgeons bring a unique viewpoint on clinical relevance. Surgeons have a different perspective on current problems in the field in regards to things like imaging for surgical planning, surgical resectability, strategies to reduce recurrence after surgery. Surgeons make unique observations about the clinical presentation of different diseases and know their patient's history and risk factors, and can also contribute to whether or not a particular design for collecting tissue, particularly intraoperatively, is going to be feasible or not feasible. As a surgeon, participating in biobanking and translational research efforts can also be very rewarding and also very important for a surgeon's career development. So for me, working with biobanking projects has really helped me become part of a team, which is a really fun way to meet people and really make more progress with different research projects. It allows you to make a meaningful contribution, and really it can be a platform for future work. And biobanking is a bit of an investment, and I'll give an example of how you might participate in a biobanking study, and it might take a long time to end up actually being able to get something out of that study in terms of like a concrete project. Of course, some projects are going to be able to be completed sooner rather than later, but there will always be things that can come many years after you've collected samples. So one example is a project that I was involved in when I was doing my breast surgery fellowship. So about 8 or 9 years ago, I was helping with a study that we call the tipping study. And so we prospectively consented all of our patients with breast cancer who were undergoing surgery and asked if they would donate blood and bone marrow at the time of surgery. So these were samples that all of the breast surgeons collected, and we ended up collecting these samples on over 1,100 patients. And now, several years later, that I'm very interested in lobular breast cancer, I've been able to go back to this repository and actually pull out the patients who've had lobular breast cancer and look at circulating tumor cells and disseminated tumor cells in those patients. And I won't go through the data, but this has resulted, several years later in a project that is ongoing and has been very fruitful, and something that it would have taken years to be able to accrue these patients if we had planned to do this prospectively with this question in mind. But instead, it was this effort to collect these samples with the idea that different researchers would come up with different research questions later, as well as some of the initial questions that were being asked. So to summarize, I wanted to share my perspective that surgeons are an integral part of biobanking and translational research teams, and that participating can both improve the quality of a research study and also can provide benefits for surgeons because a robust biobank is really a resource for many future projects. Thank you so much for the opportunity to share.
Thank you so much, Rita, for an absolutely wonderful presentation. We've had a good overview. If I can ask the panel all to come back for our discussion session. So what we've heard so far is sharing of expertise and opportunities that we can collaborate between us, the importance of communication with patients and between us as colleagues to improve our standards, opportunities for sharing of knowledge, especially rare cancers across globally. Information in biobanks can be used in real time and in the future, especially for especially we can think about future proofing that we heard from Sharon. The governance of biobanks and ethics, and how biobanks can collect information longitudinally. And the really important thing we heard from Rita was how surgeons can get involved in translational research and how we have an important role in that. And overall, I think the main message is being collaborative work for best practice is what we need. So if I can hand over to Maria to ask the first question to the panel.
Yes, thank you very much. It was wonderful. And during the speech, I thought a lot of questions. I have now one fast question and then a longer one. So my first question will be to Rita, actually. So in your practice, who is consenting patients to participate in biobank? Because with Sharon, we had a lot of discussion about this previously, if actually the surgeons should be the one to consent, or it should be well, in Bulgaria, we don't have research nurses. We don't have resources actually for this, but how it is legally arranged this in your country?
Yeah, so I know that there may be different regulations about this in different places. And for us, we are allowed to consent patients as surgeons to participate in biobanking studies. I find that it is easier if we have a research coordinator who is coming and obtaining the consent. So if there's a project which is a funded project and they have the resources to actually have a coordinator, I find that that works best. We have the same problem where oftentimes the consent forms are rather long, and so it does take a lot of time. And I do think it's a little bit hard to ask the surgeon to take that much time to actually do the consent. We have other projects that are smaller institutional projects where they're not funded, and it's just an investigator is trying to obtain some tissue, and they'll ask the surgeon if the surgeon can just get the consent, and then we do that. But I find that it's just, it's a little bit less practical. And I do wonder about some of the ethical issues of, the surgeon having a little bit of a bias and maybe influencing the patient unduly, but we don't have any restriction against the surgeon doing it, and just being very straightforward about what are the benefits, if any, and the risks, if any, for the patient to participate.
Sharon, I wonder if we can bring you in at that point regarding the benefits for the patients, because you've done quite a lot of information sharing with patients.
Yeah, I think, you know, I suppose one of the things in the patient information leaflet is always, you know, this may not benefit you, but it will benefit future patients, you know, and that's a key message to get across. And you know, having worked and consented patients over the years, you rarely have someone refusing to participate. They're always willing to say, look, if it'll help someone, I'm happy to donate my samples. So, but I think there's a benefit of having patients involved in that whole process of developing your patient information leaflet and consent form in that aspect of it, because it makes you think about things that you may not necessarily have thought about, you know, in the process, what's understandable. But yeah, usually I suppose the biobanking itself may not benefit the patient themselves, but future patients.
And Sharon, do you normally have a way to disseminate that information to colleagues and other practitioners? Is there a process that you specifically use in Ireland?
In terms of the biobanking, is it?
Yes.
Yeah, well, I guess we're doing more within the hospital itself, and it's really only in the last few years, I would say, since the whole pandemic, you know, that you know, we weren't allowed to put out leaflets in the hospital. So everything is kind of coming back now, that you can promote that information, and there have been seminars with, you know, with our colleagues in the hospital, but it's very much hospital driven at the moment. I wouldn't say there's a national effort, but hopefully with the COVID biobank, it will promote things nationally.
Yes, and at that point, Jean, maybe if I could bring you in to add a few comments as well, please.
Yes, so of course, I mean, we've seen the role of the surgeon and the role of the physician or gynecologist, who's there in liaison with the patient. And I mean, we don't always have the luxury of having a research nurse or a research coordinator, because of course that would be ideal, but I mean, realistically, so convincing, as Rita did, convincing the clinicians, the surgeons, the oncologists because they are the closest to patients. I mean, by having them convinced on the need of having biobanks, and biobanks which are robust, which of course you have all the data there, which is ethically obtained, that will ultimately then lead to further research and ultimately further improvement in the patient's care. Mm-hmm. And that would benefit, of course, the rare cancers, where you can have sharing of information, not just within that hospital, but within the country or within different countries, but also for other conditions which, although not rare, they're common, but still there is still more need for knowledge in order to improve the diagnosis for patients.
Thank you, Rita. And that, Jean, that's really important, isn't it? Using the knowledge from one cancer that we've attained and how we can extrapolate that information for others to improve our knowledge of other cancers. Wolfgang, I wonder if you can hear us and if you could would like to add anything. I'm not sure if Professor Thelsa can hear us. I'll go back to Mariela and ask her, may we have the next question for the panel?
Yes, I have them a lot. So I know that Ireland and Malta are now in process of establishing their national biobanks. So my first question would be, do you think it can happen actually soon to have a national biobank? What do you think? This is the first part of the question.
Well, from Ireland, as I said, we've seen progress that what COVID has done. So that's brought about a framework for a national biobank, and I think we definitely can build on that and the lessons that they will have learned in developing a national biobank. And I think if you have that buy-in from all parties, absolutely. But it's going to require funding and sustainability going forward. And I know the National COVID Biobank only got a few years funding to start with, so we have to think, how is that going to be maintained going forward, because it's definitely a resource that needs to be developed. Yeah.
And to add to what Sharon has said, so in the case of Malta, it's actually, there's the node for BBMRI. So what Malta has done and what the University of Malta has done has linked up with BBMRI. And I think that has been very important. I mean, especially, as I said, for a small country, and in order to not to have to reinvent the wheel, but be part of an ongoing project. And as Sharon said, I mean, this is always work in progress, because of course we learn from each other and we try to harmonize and standardize so that eventually there could be sharing of information, samples, data, etc.
Yeah, that's really important, isn't it, Jean? The fact that we get this data and we can share it with bigger communities, and as our knowledge improves, our expansion of that knowledge will of sharing will improve, and with big data and quantum computing and AI, who knows what the future has. And I think that's a really important thing. Would anybody else like to comment on that before I ask Mariela to ask the next question? Okay, we will go over to you, Mariela. May we have the next question?
Yeah, so I was thinking, because Sharon and Jean knows, we have a project for a virtual biobank. So wouldn't be a virtual biobanking a way to bring the national biobanking closer? And what I mean in this is, like, if you have a virtual biobank, you don't need a storage place to where all the samples to be, and it should be cheaper and easy. In virtual biobanking, different places are responsible for their own tissue samples. So wouldn't be this more easier to go for a national, for bigger biobanks?
I think it depends on what you're collecting, Mariela, because if you're collecting tissue and they remain in the hospital archives, which they're going to be there anyway, then yes. But if you're collecting bloods and other, bodily fluids, then you've got to think of, not every place has the proper storage for those. So it depends on what's available. But I think most places now have -80 freezers. But it's the proper monitoring and all of that has to go with it. But yeah, I do agree that you can have things stored on site, and then if you're sharing, you just have to have the proper facilities in place, I think, and depending on what people need the samples for.
And the other thing is, Sharon, I guess one of the opportunities is in the virtual biobanks is the data you've collected so far on a sample is to actually tabulate that into the virtual biobank that then other colleagues have access to. Do you do that in the biobank in Ireland at the moment?
We wouldn't do it currently, I suppose, in terms of a lot of the biobanks here are just standalone biobanks. We do collaborate with other groups and we share coded data once we've gone through the whole legal agreement process, but we don't necessarily insert our data for anyone to avail of. So it's all done through legal agreements and material and transfer data agreements with our collaborators.
Yeah, and I guess that's important. As long as we have it in the virtual world or access to that data, then the legal requirements can be followed to ensure that patients have the right consent and it's meeting. I think that sounds perfect. Jean, would you like to add something to that as well?
Yes, so I mean, I've had a recent discussion with our advisor to the biobank. I mean, and I know she's one of the participants, Dr. Brigitte Loul. So she herself is an expert in the legal and ethical aspect. And in fact, I mean, she together with Dr. Olga from Greece, I mean, they are the leads for working group 3, which is specifically on the legal and ethical aspects of informed consent in biobanking. So the thing is that virtual biobanks, I mean, to some extent, there's already virtual collaboration. So, for example, if you take BBMRI, I mean, they have their harmonized protocols. And of course, I mean, each country will need, and each center would need to stick to those. The problem comes when it comes to consenting. the current and future use, like who ultimately will be using that. And that is something which we are all, basically by we, meaning the greater we, I mean science, striving for, because while it's very important that there's a sharing of information, have to keep in mind always the data protection of the patient. And that becomes even more significant when it comes to the rare, because they are easier to be identified. So, I mean, it's a challenge which we're all striving to, get there.
Yeah, and it's learning as we're doing it, isn't it? And progressing and improving systems as we go along. And Rita, if I can bring you in at this point, from a surgeon's perspective, obviously you want to do the best for your patients. And when you put in samples, do you want to know what's happening to those samples or what data we have? Do you get updates, or would you like updates? Where would you like it from a surgeon's perspective?
I think that, from my perspective, I have different levels of involvement in different projects. So there are some projects that are looking at, so like I said, I'm interested in lobular breast cancer. So any sort of breast cancer related project, I really try to go to the meetings and be part of the team. And yes, I'm very interested in what's happening with the samples, and I want to learn and contribute what I can. Other projects, I am a little bit more of like a technician, for like, I don't know anything about, skin. And so someone needs skin samples. And so I'm just providing the skin samples. And so I don't really know what's going on with those. So I think that I certainly wouldn't want to only do that. I think that would not be very, very rewarding, but I think that there is a practical aspect as well. Individuals are training.
Thank you. I think we lost you there for a moment, Rita. At least I did. It's if I've got that right, basically, as a surgeon, for the research or the area you're personally interested in, you would like data and information on what's happened to the things. But for other areas where there's sample being taken for other biobanks, you just want to be able to provide the information. That's correct, isn't it, Rita?
Yeah. Sorry about that. Yes, exactly. I was just saying that I think that there's a range and of interest in different projects.
I think we've lost Rita again.
And I think depending on the surgeon's
Okay, I think we lost Rita there for a little moment, but I think we've gathered what the main things were. And Mariela, shall we go to you for another question?
Yes. I was thinking, well, I think it's quite complicated how to actually improve the care for rare gynae patients, or for rare cancers, the patients with rare cancers. And I was thinking, wouldn't be the biobanking actually the most cost-effective way? And I'm sorry to bring this again, but the virtual biobanking, because rare, when how to prove cost effectiveness in this if you have so little experience and so little sample. So maybe if you have actually maybe the virtual biobanks could help the most in rare cancers. So Jane, what do you think?
No, you're definitely right, Mariela. I mean, cost effectiveness, I mean, is definitely the most important, aspect, when it comes to virtual biobanks. So yes, that is the way forward. And again, from what Sharon has highlighted, I think there has been a big progress made, especially in the last 2 years, where we have moved to a more virtual world. So even accessing patients, I feel that everyone, starting from myself and starting from the experts, but also patients, they've become more virtual, more familiar with virtual, and then especially the younger generation. So yes, I definitely agree with you that cost effectiveness in terms of virtual wellbeing is the most important strong point. That's why we have to strive to harmonize all where it comes to what do you collect, how you collect it, and having documentation, so that when eventually we're in a position to share data, of course, you don't have a mixed bag, or the samples have been treated in the same way, so that the results that you get following tests that you do on your samples, they make sense and they reflect reality.
Thank you, Jean. And this actually links into one of the points that one of the participants mentioned, that, you know, surgeons' time is money, really. And how do we actually accommodate, include that in as well? So maybe Sharon, if I could come across to yourself, and is that actually linked in to your biobank, the cost of the surgeon's time in actually securing the samples?
Do you mean, do we, so I suppose we're fortunate here that we have a very, I suppose, research active gynae oncology team, so who actually do the consenting for us and also take the samples in theatre. But we always, and like what Rita said earlier, it's like, who's going to take that sample? They just have to make a phone call to one of us to say, okay, we have a sample in theatre, and it's having that person ready to run over to theatre and, you know, bring the sample to the pathologist then is really important. But it does, I appreciate it takes time for the team to do the consenting and to take the samples, and some samples might be a bit more involved. Like we work on circulating tumour cells, and we take samples from the ovarian vein during surgery, so that's an additional sample that wouldn't be the norm, and it's the surgeons that are interested. So having that research interested personnel to work with you is really key to the success of the biobanking, really, and we're very fortunate here to have that.
And I guess one of the things is, because for the surgeon, they're obviously operating, and that will take extra time to do. And it's something that as we create more and more biobanks is to consider that cost of the surgeon. And I wonder, Rita, if I can bring you in at this point to ask about when you're collecting samples, it is taking you time to collect these samples. Does it, do you have this conflict with your other clinical work, or is time allowed to collect these samples?
I hope I'm back on the internet.
Yes, you are, Rita.
Okay, yes. Thank you. So to be honest, sometimes it is a challenge, especially when we're, you know, in a busy clinic and we need to go do a procedure in the next room. I think that a lot of the logistics are really important. Like if you set up, you know, a tray that has all of the equipment that you need, and someone already has a consent form signed, honestly, it doesn't take that much time for the surgeon or whoever's doing the procedure to go in and obtain the tissue. The problem is when we're not organized, and I go in to do the procedure and we're missing the, you know, the prep solution for the skin, and we don't have the consent form. And, you know, so I think that prep work to get all the logistics taken care of saves a lot of the surgeon's time. So some planning in advance, I think, is very important.
That actually links in really nicely with what Sharon said, is to be on hand and ready to run when required. And I think that it's a bit like an orchestra, to orchestrate everything together to make it work. And that's where we really push the boundaries, really, within the surgical field. Mariela, may we have our next question, please?
Yes. Yes, there is something what really bothers me personally in this biobank research, is that very often there are no samples from patients actually from, let's say, Eastern Europe, because I'm from Eastern Europe, I'm from Bulgaria, but not only Eastern Europe, in many parts of the world, there are no biobanking, there are no samples taken from there for research. So basically, when we find out something in the lab, and this it's important for treatment of patients at the end, it's drug related or something. This lacking of information from some parts of the world, how is this affecting the treatment? And maybe I'll just listen, like, can you comment on this? Maybe we can do something to have more samples from these parts of the world.
Yes, that's very important, isn't it, Mariela? We talk about personalized care, about making our strategies for treatment to fit the patient. But if we don't have biobanks that use data inclusivity and that diversity and of the range of data is really important. So I wonder, Sharon, if I could go across to you first, and maybe you could give me an overview of if you're mapping where the samples are coming for ethnicity, which parts of the world or which parts of locations, obviously you're doing a national biobank, and how you're meeting this particular requirement.
Yeah, I agree. That's a difficult one, Mariela. And you know, I think, you know, here in Ireland, I suppose the majority of our populations would be Caucasians, you know, white Caucasians. So, but we would have representatives from other ethnic groups, but not enough, I guess, to do any analysis really, you know, in terms of biobank tissue. So I agree, it's probably larger, more international studies and the clinical trials that might have more of a reflection. But there's always a push, and there's definitely a push here to kind of try to reach those hard to reach communities, you know, even the migrant populations here in Ireland. And there is a lot of work going on about promoting various aspects of health information and awareness amongst that group. And it's something that we tried to do with our biobanking awareness event, was to reach out to those populations. And we even see within Dublin, which is a small city, there is differences in the cancer outcomes, you know, depending on what area you come from. And that's probably where that little video I showed, that's where that stemmed from really, because it was part of a little grant to try and get out there to those hard to reach communities. So that was done with school children in a disadvantaged area of Dublin, because their knowledge of biobanking would be a lot less than maybe more affluent areas of Dublin. So there is a push, and there's a lot. The funding agencies are doing a lot here in Ireland at the moment to you know, having specific funding calls so that you can reach out to those hard to reach communities. But I agree, it is an issue, and it's an issue globally.
Thank you, Sharon. I think that's really important to have pots of funding specifically there in the area to actually reach out to these hard to reach communities. Jean, if I could bring you in at this point and ask you for your expertise or your knowledge in this area.
Yes, so I do agree with Sharon that getting the public involved, and the beautiful example that you showed us, where you actually have young people, like 16-year-olds, actually coming from disadvantaged areas and doing it in a medium, like in a sort of cartoon, simple language, but giving all the information. I mean, it's great. And it is a fact, I know again from my colleague Bridget, who I know is with us on this meeting, that it's always a problem. I mean, that there is a tendency wherever you are in the world that you tend to get people coming, for example, from a more affluent, higher education, and they tend to be more Caucasians, who tend to be the ones going for biobank. But the reality is, you know, not that. And of course, I mean, if you happen to be a member of a minority group with a rare condition, possibly with difficulties even in communicating or not knowing the healthcare system because you recently just moved in there, is an issue. So again, that's another challenge when it comes to ensuring that your samples in your biobank they are showing equity, they are representative of the population.
Thank you. And Rita, I'm going to bring you in because as the surgeon, you are the front facing for our colleagues in collecting this samples. Is there anything you're doing specifically or your experience in the area regarding this?
Regarding sorry, could you repeat
regarding the equality and the diversity issue, that we're not getting samples from all our populations that we treat, we only get them of part of the population.
Right. Well, I think this is a huge issue globally, as has been mentioned, and I think in the US we have a major problem with this, with an unfortunate history of medical experimentation on marginalized populations in the US, which has led to a lot of distrust among certain groups of people of the healthcare system. So it is a big challenge. And I do think that relationship between the patient and their physician, I think can help overcome that. And that's another reason why it's so important that there's a trusted person who is discussing this with the patient and sort of reassuring people that their information will be cared for carefully.
I think that's an important thing you've raised there, Rita, is that it's the historical background that we're having to deal with. And I think it sounds like another webinar, Mariela, coming up, another idea of a webinar. I think it would be useful to have a sharing of maybe a discussion about how we do improve inclusivity and diversity and the equality, and how we actually get to these hard reached areas, because as we are getting better at it, and I hope we do get better at it, hopefully we can share that information between us to reach other communities that we've not been able to. And so I think definitely another webinar coming along, Mariela, in a year at least. I think we should be penciling that one in. And I've noticed in the chat as well that people have highlighted that unfortunately there is a bias towards Caucasians and of higher educational background. So in the chat, we are monitoring the chat. If you have any suggestions or any great solutions, do pop them in the chat, because we do want to hear from you as participants as well. Mariela, I wonder if we can do another quick cheeky question before we finish.
Yes, I think the last question would be regarding improving the care. And actually now Rita is working with lobular breast cancer. Jean and Sharon, they're working with rare gynae cancers. We discussed when we met that actually rare cancers mean one in one country and another in another country, but still what we should do to improve the care for our patients in rare situations. Maybe this would be the good final comment.
Yeah, I think this is so important as well. And because each cancer has a different rarity depending on which country we're in. And Jean, so if we could start with yourself first for this one.
Yes, so thank you for this question, because as you rightly said, I mean, if we take the definition of rare care net, and actually that's the definition we decided to stick to, it's like if there is an incidence of less than 6 per 100,000. Now, if you take, for example, cervical cancer, so cancer of the cervix, and in a number of countries, especially where screening, cervical screening, pap smears, have been in place, and there is a good follow-up system, and there is even the HPV vaccine. Actually, in those countries or in those regions where the uptake of the vaccination, of the HPV vaccination and the screening is in place and it's rigorously followed, in those places, you can actually consider cervical cancer as a rare condition. If we take it in general. Again, of course, the same cancer in other part of maybe the same country or in the same continent is still not rare because of the lack of preventive measures. Okay, so yes, in my opinion, ultimately, any disease, be it cancer, be it common or being rare, if we keep the patient at the center, it all merits attention wherever you are in the world. So although, okay, for the sake of this GYNOCARE, the focus was on rare in order to try to harmonize and improve those rare diseases. Ultimately, whatever applies to them, especially in terms of biobanking, in terms of patient engagement, patient consent, and the trust that patients have with their surgeon, with their clinician, in order to help themselves and help others, it's irrespective of whether a condition is rare or not, I think.
Thank you, Jean. And Sharon, if we could ask you.
Yeah, I think Yeah, sure. I think having initiatives like this cost action where we're all collaborating so that, you know, if we do have those rare cancers, that we have strength in numbers, you know, that we have from across countries. And I think, you know, funding more initiatives like that and developing those collaborations will prove very useful going forward for the rare cancers.
Thank you. Rita, would you like to add something?
Yes, I think because, you know, in breast cancer, there's many different subtypes. I think if you're trying to do any kind of meaningful research in a subtype of breast cancer,
I think we lost Rita again.
Mm-hmm.
I'm so sorry about that. Hopefully she should reconnect with us. I think that was the last question we were going to have. So I think there's a lot of opportunity that we can have in actually collaborating and working together. So I hope by the end,
having a biobank and
oh, we did get Rita a bit there and she's disappeared again. Okay, so let me just summarize where we've got to this evening. So we have an understanding about the possibilities of biobanking is providing for participating in translational research. We have a better understanding of the process of establishing a biobank. We have had some contacts given today where you can reach out to as participants, and we encourage you to do further reading and look at the ESSO website for further courses. I want to thank the wonderful panel who have made this webinar possible. You've all been fantastic, and I'm sorry if we put a lot of pressure on you to make this absolutely perfect. And last but not least, I would like to personally thank Mariela, my co-organizer for this session. She's tolerated me, all the extra calls and everything, and she's absolutely fantastic. Thank you, Mariela, as well.
Thank you. Oh, it was really great. I'm constantly learning from all of you all the time. So I will keep on asking you. The questions are not finished with this webinar, so be prepared.
Yes, and I do encourage you to look at the ESSO website where there are further webinars. And you don't know, we might be back in a year's time discussing how we include equality and diversity and have a wider range of things. And do ask any other further questions. We've tried to address all questions that came in today. If you have any outstanding, do contact us again. And thank you so much. And with that, we all say good night to you.
Thank you.
Thank you.
Bye-bye.
Thank you, everyone. Bye.
Thank you.